All right. You can see the screen, is it not? Okay. Rose, you are there?
Yes, sir.
Okay. See, I've sent you a word format of the what you call whatever we discuss, so that it will be useful when you revise for your exam, as well as it's a summary. If you find it useful, you tell me. Then only I will send in the other topics, because it takes an effort to do that. If it is you, some people wrote to me telling that his MCQs are very good for knowledge, but when you write in the exam, you write short notes and essays, and for that we would like to have an abridged version of whatever we discuss. Therefore, that was the reason why I sent it to you. Anyway, today it's a very, very, very important vaccine, that is the rabies vaccine. And it is a life and see, when we are doctors, we often say we take life and death issues, decisions, life and death decisions. In actual practice, we do that, but very, very rarely. But one decision which makes a life and death issue is the rabies vaccine. How to give it, when to give it, what sincerity you show it, etc. And your knowledge is also important. And the most funny thing about rabies vaccine is there is the national guidelines, there is the IAP guidelines, there is the WHO guidelines, and on the top of it, there are so many articles on it. And if you go for an IAP meeting, they will say that we should follow the national guidelines. But the point is that it there are significant differences between this, and these can have medical legal issues when you start practicing. Therefore, first you should know what you would follow. Is not as simple as you think. Sometimes you can run into severe trouble. Already there is a lot of questions because fully vaccinated children, more than 13 or 14, have died this year in Kerala. Therefore, everyone, if you had given it in private practice, you will definitely be questioned about it. Therefore, we will come into all aspects of it. You can read it now. Can you read Paris?
Not games.
You can see it?
You can see that MCQs of rabies vaccine. That's why.
It has changed, no?
No,
Not changed?
not changed.
My God, what happened? It is the old one. I have changed it here. I don't know why you're not getting it. Not at all changed.
No.
I'll come to that once more. Let me see. Can you see anything?
I can see.
What's it?
First question, sir.
Yeah, okay, read it now.
A 5-year-old boy presented 48 hours after being bitten on the forearm by a stray dog. The wound is deep with minor bleeding. He has never received rabies vaccine before. What is the most appropriate next step in management? A. Administer rabies vaccine only. B. Clean the wound and administer rabies vaccine and human rabies immunoglobulin. C. Observe the dog for 10 days before starting any treatment. D. Administer equine rabies immunoglobulin only. Answer B. Clean the wound and administer rabies vaccine and human.
Okay, now that's the right answer, straightforward answer anyway. Now, may I ask you one question? If it is not a stray dog, it's a dog of your neighbor or your own dog, will you observe it for 10 days before starting treatment?
No, sir.
Okay, that was the thing before. Now we don't do that. Okay. Can you read the answer?
Answer B. Explanation. This is a category 3 exposure, transdermal bite with bleeding. WHO and IAP guidelines mandate immediate wound care, administration of rabies vaccine, and passive immunization with either a human rabies immunoglobulin or equine rabies immunoglobulin. Observe Version of a stray dog is not reliable.
Okay.
Reference Rabies category.
Okay. Now the second question.
Which of the following is not a feature of a classic hydrophobia in rabies? A. Aerophobia. B. Photophobia. C. Ascending paralysis. D. Hydrophobia. Photophobia.
Okay, you can get ascending paralysis, you can get aerophobia. In fact, if you just wave your hand in front of him, he might develop this one. Therefore, that is given in this answer. You know that. I written hydrophobia, aerophobia, and photophobia. Photophobia is given here in the answer. Surprising, huh? I didn't know that. Photophobia is a feature of this. Therefore, the answer is wrong then. Okay, question number 2, answer is wrong. My God, I didn't realize it. Photophobia can also be a feature according to this. All right, that's why when you read MCQ and go through back into you will understand. Remember, a child presenting with encephalitis, you must immediately look for hydrophobia. How many of you do that? Unexplained encephalitis, you must ask the child to drink a cup of water, which you will not do. Okay, next.
A 3-year-old girl has small abrasions on her leg after being licked by a stray dog. The skin is broken. How should this classify according to WHO? Category 2.
Category 2. Okay. Look at the answer.
Category. Lick on broken skin constitute category 3 exposure, requiring full post-exposure prophylaxis. Indicate a skin licking is category 1.
Intact skin is category 2, 1. Therefore, remember, you have made a mistake which could have cost the child the life. Remember, look at what is given here. What is category? Read the category fully.
Category 1, touching or feeding animals. Animal lick on the intact skin, no exposure. Category 2, nibbling of uncovered skin, minor scratches or abrasions without bleeding, exposure. Category 3, single or multiple transdermal bites or scratches. Contamination of a mucous membrane or broken skin with saliva from animal licks. Exposure due to direct contact with a bat. Severe exposure.
Okay. This is the World Health Organization. Huh? The World Health Organization, it says direct contact with bats. And what is written on the left side, you read it in.
It is essential that either body to be entire body to be examined for small bites, especially for small children, and every bites be infiltrated with rabies immunoglobulins or monoclonal antibodies. Category 2, without oozing of blood. Category 3, leaks on mucous membrane or broken skin. No mention of saliva.
See, what I'm trying to tell you is there can be many problems. Many times when you have a scratch on the body, there'll be an erythema around it. You don't know whether it's bleeding. Here, category 2, without oozing of blood, that means the blood should flow out. But many times what happens, the dog will bite over a cloth. There'll be no bleeding, but the cloth will appear red. That itself is considered as a bleeding. Now, what happens when the child puts his you understand, many children go and kiss these dogs, and the dogs also lick the child. Suppose the dog licks on the mucous membrane, say on the mouth or something. Will you call it category 3? Yes, it is. According to 3, contamination of mucous membrane immediately becomes category 3. You understand? That is why this is you must go back. Now you made a mistake. You said category 2, in which case you wouldn't have given the immunoglobulin. That would have been a dangerous mistake. Therefore, before you say that it is not category 3, be double check, triple check with what is given here. Okay.
What is the recommended dose of a human monoclonal antibody rabies shield for post-exposure prophylaxis?
Well, I am not a person who's very happy with such questions because we are not supposed to remember the doses, but still some MCQs ask these questions. Okay. In anyway, the answer is 3.33. Okay. HRG is 20 and ERG is 40. If you can remember, it will be good. Okay. Rabies shield is 3.33 international units per kg. Okay. Now we go to a next question.
Which of the following is true regarding WinRAB?
Twin
A,
rab, okay.
it is a single human monoclonal antibody. B, dose is 3.33 international unit per kg. C, it contains two murine monoclonal antibody targeting different epitopes. D, it can be used without vaccine in minor exposure.
What is it? Twinrab is a monoclonal antibody. Rabies shield is by Serum Institute. Twinrab is by another company. I think it is Cadila. And it has got two monoclonal antibodies, while the Rabies shield has got only one monoclonal antibody. Meaning, when you say monoclonal, it targets one epitope only. Therefore, the answer is what? It contains two
Two
murine.
murine.
Read the answer.
Explanation. Twinrab Zidus cadila is a cocktail of two murine monoclonal antibody. Doca Vimab,
Microbab.
targeting distinct epitopes of G protein. Dose is 40 international unit per kg. Must be used with vaccine.
So 40 international units is ERIG dose. Therefore, same dose for twin tribals. Now, monoclonal antibody is a very important topic, and what it is, what is the stand of it. You should have a clear idea in the mind, because monoclonal antibody is what is given in private hospitals. It is not given in government institutions. And the national guide, whenever you have a national guideline, you are supposed to follow the national guideline. But the national guideline does not even mention monoclonal antibody. It's a terrible mistake on their part, I would say. The answer, when you go for meetings, they say that is because the monoclonal antibody may not be useful in all the epitopes. It may not cover all the epitopes. The epitope is a part of a gene to which the antibody attaches. That is not true. Therefore, we will be discussing in the next few slides. I think the next few slides contain information from IAP on monoclonal antibodies. I will summarize it at the end. Majida, can you read it? Majida, you're there, yeah?
Yes, sir.
Yeah, read it.
Passive immunization. Monoclonal antibodies. Rabies Shield Serum Institute of India is a recombinant human immunoglobulin IgG1 anti-rabies monoclonal antibody S2R mAb, which binds to the ectodomain of G glycoprotein. Rabies human monoclonal antibody Rabies Shield neutralizes 25 different wild type of street rabies virus isolates. Efficacy is proved in an animal model of pre-exposure prophylaxis in post-exposure prophylaxis in Syrian hamsters challenged with wild virus.
You can read the whole thing.
Rabies Shield, the recombinant.
One minute. We only read. See, this is given in the. This is not from the IAP book. Is it something I have written here? It is from the some other journal. Just read what is given in the bracket.
The S2R mAb was developed by Mass Biologics, Boston, Massachusetts, USA, under the name 17C7, then further developed under the name S2R mAb.
SI, that's Serum Institute of India.
SIR mAb.
That is monoclonal antibody, Rabies shield monoclonal antibody. Therefore, why I put up this slide is because suddenly from the next slide, the IAP talks about 1767 without telling what it is. Now read the sentence. Okay, read rest.
Human monoclonal antibody 17C7 was the most promising antibody identified because it neutralized all rabies virus isolate tested. Then human monoclonal antibody 17C7 recognizes a conformational epitope on the rabies virus glycoprotein, which include antigenic site 3. Monoclonal antibody 17C7 protected hamsters from a lethal dose of rabies virus in a well established in vivo model of post-exposure prophylaxis. Advantages of RMAP include easier to produce in bulk and adverse reactions of blood-borne products are avoided. Skin tests are not necessary before administration of MAPs.
Okay.
Dose is 3.33 international unit per kg. Post-marketing surveillance following the use of 50,000 vials has not reported any serious adverse events. RMAP can be administered till 7 days after the first dose of vaccine. The presentation 100 international unit per 2.5 ml, 40 international unit per ml vial and 250 international unit per 2.5 ml of 100 international unit per ml vial. Then twin wrap, Zydus cadila. Twin wrap is a combination of two murine monoclonal antibodies,
Forget
Doca-ravimab
the names. Forget the
60 to
names.
70.
Yeah.
Okay. They bind to two different epitopes on the G protein expressed on the surface of the rabies virus. The two monoclonal antibodies bind to and neutralize both rabies and rabies-like viruses, preventing their infection into the neighboring cells.
Okay.
The cocktail of antibodies was...
Oh, sorry. 1 minute. Yeah, okay.
Okay. The cocktail of antibodies was also found to neutralize rabies virus strains isolated from dog, canine, human, and bovine sources from southern parts of India. Composition,
Okay,
dosage, and
that's enough in this slide, doctor. Next slide, you read.
Twin wrap must always be used in combination with rabies vaccine as part of post-exposure prophylaxis in line with recommendation of WHO. Recommendations for monoclonal antibodies. ACVIP strongly recommends the use of MR antibodies over rabies immunoglobulins in the management of category 3 bites. Human monoclonal rabies antibody, Rabies Shield, and murine cocktail monoclonal rabies antibodies, Twin Wrap, both are available in India and recommended for the post-exposure management of suspected rabies exposure.
Okay. Now, let me tell you a few things here because you will be attending many meetings and everything. The government sector, for some reason, I have found that even in IAP meetings, they begin with telling that there are multiple guidelines. Too many cooks spoil the broth. There are WHO, as I said, so many guidelines, but we will be following the national guideline. That's very good, correct statement. But the national guidelines does not mention 2019. They have come out with another one in 2023 on certain other aspects of it. No mention of monoclonal antibody. This is surprising because this has been gone into a WHO. We will come into it. WHO has said it's good. The Lancet articles are there in which they have praised it. Only thing is, Rabies Shield is a single. The other one has two monoclonal antibodies. Therefore, naturally, Twin Rab may be superior, but even both are supposed to be very, very effective. Now, if you ask them, they will tell you this is because monoclonal antibodies are very specific and it may not be useful in all the rabid dog bites in Kerala, which is not correct. Remember, whatever you say, because it can have legal issues. If you give monoclonal antibody in your private, which I think you should, because monoclonal antibody, there is no blood product. The consistency of its is from one batch to the other is almost same, unlike the equine immunoglobulin, which the consistency varies from one to the other. There is no anaphylaxis in this. Anaphylaxis is very, very rare. Therefore, and ACVIP is strongly recommended. Remember this. IAP guidebook clearly states ACVIP, therefore you are fully justified in doing it. As we go along, we will find this, because it's a life and death issue, you can be questioned when you don't follow the national guideline. Dr. Pradhaban has joined or not? He has gone for some meeting. Are you there, Pradhaban? I can't see who are all there. Anyway, I think he has not joined. We would like to take his opinion on this. Now, next question. Can you read, Majida?
A child received complete post-exposure prophylaxis 2 months ago and is bitten again by a stray dog. What is the recommended management? A full post-exposure prophylaxis with vaccine and immunoglobulin, then wound care and 2 doses of vaccine on days 0 and 3, or C only wound care, D single dose of vaccine. So only wound care, sir.
Okay, yeah, that is the read the explanation.
If re-exposure occurs within 3 months of complete post-exposure prophylaxis, only wound care is needed. No vaccine or immunoglobulin is required.
Okay. Therefore, this is the, even in the WHO, I mean, this is clearly written. You have already said that. Read that what is given in that highlight yellow bracket, yellow one. You can see it?
Yes, sir. If an individual has a repeat exposure for less than 3 months after a previous exposure and has already received a complete post-exposure prophylaxis, only wound treatment is required. Neither vaccine nor rabies immunoglobulin is needed. For repeat exposure occurring more than 3 months after the last post-exposure prophylaxis, the post-exposure prophylaxis schedule for previously immunized individuals should be followed. Rabies immunoglobulin is not indicated.
Previously immunized individual. What is it? It will come to later. Wound washing and immediately, that is here, that is previously immunized individual of all age group. Category 3, you will have to do wound washing or 4-site ID or 1-site MD 0 and 3. Therefore, if you are giving intramuscular and private, you will have to give 1 and 3 for category this one. So for when you are re-exposed, this is called the re-exposure after 3 months. You give 0 and 3. Okay, we will come to that. I think this is the important thing to remember. Okay, now come.
Which of the following statement about intradermal rabies vaccination is true according to IAP 2022? Intradermal route is preferred for all children. Intradermal administration is not recommended in individual practice. Intradermal saves 50% of vaccine volume. Intradermal is the standard care of national guidelines.
What do you say? Rose, you want to answer? You are there?
For intradermal administration is not recommended in individual practice.
Okay, that's the answer. Give the read it out, Majida.
The intradermal administration is not recommended in individual practice due to risk of improper administration and legal implications.
It's not only that, because in individual practice, in your practice, there are 5. The main idea of giving intradermal is to save the vaccine. Unless you have 5 people to give on the same day, you cannot give you are not saving anything. While in government sector, it's a different thing. In general hospital, I understand certain days there are 150 people to take the immunization. Therefore, we may have one in 2 or 3 in a week. Therefore, there's no point. You'll have to waste the rest of the vaccine. Now here, if you read it, this is 2018-19 IAP guidebook. Okay. Now read here. It is clearly written: intradermal administration is not recommended for individual practice. And also remember, for pre-exposure, 0.3 is the dose. Why I'm telling you, it will come later. Now, in the purple book, which has come in 2022, does not make the statement intradermal administration is not recommended in individual practice. This is what the IAP says. It doesn't say that we are going back on the statement, no. But they have clearly written in 2018 that intradermal administration is not recommended in individual practice. And I would say definitely yes, because the main issue in intradermal administration, what is it? Can you say, Majid, the main problem of intradermal? Many patients who are given full immunization, full pre-exposure, post-exposure prophylaxis, 12 or 14 children have died. It's a huge issue in which, in a case, where most of the literature says, we will come to that later, that pre-exposure prophylaxis is post-exposure prophylaxis 100% effective, which is not true. But then, therefore, it puts tremendous pressure on you. You have given the injections and the patient develops rabies. Everybody blames you. They think that something has gone wrong. And what is likely to go wrong? Can you say, Faris, can you say what is likely to go wrong?
Not giving proper intradermal.
Yeah. What happens if you give, what do you mean by non-giving proper intradermal? What happens at times?
Subcu.
Rose, you want to answer?
The volume given during intradermal is only 0.1 ml.
Yeah, that is supposed to be equally. If given intradermally, 1/5 of this dose which you give is supposed to be as effective as the full dose given IM. Why? Why is it so? We have discussed it previously. It was there in my video. What is it?
Patient not getting proper intradermal injection.
Now, how is intradermal superior to other things?
Due to high concentration of this antigen presenting cells.
Dendritic cells, high concentration of dendritic cells, it is supposed to be superior, but you have to give it intradermal. Intradermal, IM good. IM has got good. But if you make it subcutaneous, which can happen very often, the child moves and it goes subcutaneous. Subcutaneous is not effective. We discussed this in vaccinology. Only some viral vaccine like measles, etc., you can give subcutaneously. And some other rabies vaccine also, they are surprisingly written subcutaneously. But when you give intradermal, 1/5 the dose, it has to be intradermal. And therefore, in the private practice, when you give it, you yourself may not know how to give it. Your nurse may not be giving much. Intradermal dose should be given in places like Taluk Hospital or district hospital, where the nurse is giving multiple doses in a time and she is quite sure about it. Even there is a problem, because suddenly she will take leave and somebody else from dermatology or somebody will come and she might give it subcutaneous. Therefore, this is a life and death issue. Remember this. Life and death issue. You give a dose subcutaneously, the child is not protected. Okay, now let's go fast. What's the next one?
A 10-year-old boy has a facial bite from a bat. The wound is small but bleeding. What is the most appropriate action?
Quick.
No
Good.
prophylaxis is needed.
No prophylaxis required, that bats are not a concern. Yeah, read the answer.
Oh. Bites from bats are high risk category 3 exposure.
Okay.
WHO emphasizes bats.
Okay, you are right, Majida, because the answer is that in Indian prophet, this one, they have clearly written that bats are not this one. We are coming into it the next. You are right, actually. Now read category 3, and you will find that exposure to direct contact with bats, severe exposure. That's what the CDC says. That's what the World Health Organization says. Bat. When do you have bat? Exposure, when nowadays people are going into caves and everything, you can get a back exposure. Now, this is a often question asked is, what animal should you give the prophylaxis? What animal you need not give? Okay. This is given in IAP, but as a column, it was given in some journal. I forgot to give the reference, but it's worth knowing it. Now, you can't read the whole thing. Main animals, monkeys are others. I mean, among them, dog and cat. And then you have mongoose, etc. But what is important is non-transmitting animals. Rats and bandicoots are not. Rats bitten by a bat is not supposed to be important. Birds and bats, remember, as per the Indian guidelines, bats are not. You are right. Birds and bats are not. You can go through the slide. I can't waste time on it. For bats are not required in IAP immunization, in IAP Purple Book and national guidelines. Therefore, both the national guidelines, this is what I say, there's a life and death issue in decisions. Standard guidelines are making a difference. Suppose somebody is bitten by a bat, will you give it or not? WHO says yes. How can you go against WHO? Then at the same time, the national guideline says no. Therefore, you are justified in not giving it. Now read what is given in the. You must know which bat, which often questions right. Bitten by a rat, should I take it? Okay, read all this line. What is given in this?
Bites by all warm-blooded animals. Exposure to wild animals. Exposure to all wild animals should be treated as category 3 exposure. Rodent bites. Exposure to domestic rodents have hare and rabbits do not ordinarily require post-exposure prophylaxis. However, rodent bites in forest areas necessitate institution of post-exposure prophylaxis. Then exposure to bats, bat rabies has not been conclusively proven in India, and hence at present exposure to bats does not warrant prophylaxis. Then human to human transmission, the risk of human to human transmission is minimal, and there are no well documented cases other than the few cases resulting from infected organ or tissue transplantation. However, people who have been exposed closely to the secretion of a patient with rabies may be offered post-exposure prophylaxis as a precautionary measure.
There's a big problem because when a patient is admitted, the nurses often refuse. And because they say actually from one human being to the other human being, it doesn't get transmitted. But it is better that if you are in a hospital, you offer them post-exposure or pre-exposure prophylaxis. Scientifically, it is not indicated. Remember, wild animals should be treated as exposure. Why I'm telling this is, and many people now go for trekking. They go into forest while walking, etc. They come back with an injury. If you ask them what happened, they will tell you, we don't know, doctor. We don't know what it is. It just happened. Remember, if you have a suspicion of a bite by something which is unknown, then you will have to give them rabies prophylaxis. Otherwise, it can be rodent bites, etc. We are getting through. Now, one of the problem with the rabbit bite, bite by a bat is it can be very small. It look like a pinprick actually. Therefore, you should know that. But as per Indian guidelines, you don't have to give it. But if I find a bat right, I would definitely give it because international guidelines and national guidelines do advise it to be given. Okay. Now, remember, can you read it? What is in the bracket?
Rabies is not transmitted via fomites or environmental surfaces. When to use rabies prophylaxis?
Okay, that's an up-to-date statement. Important. When you're admitting a patient, people are very afraid to go inside that room. And but now I understand SAT hospital even ventilates patients. Now, okay, go ahead.
Which of the following is not a reason for post-exposure prophylaxis failure despite apparent adherence? Delay in seeking care, improper wound care, use of monoclonal antibodies, direct nerve inoculation.
Is not a reason for PEP failure. Fast. Is it so important? Rose, what's the answer? Yeah, use of monoclonal antibodies. We have already said that use of monoclonal antibodies. You read it first.
Use of monoclonal antibody, example rabies shield, is associated with better compliance and efficacy. Post-exposure prophylaxis failure is linked to delay, poor wound care, unnoticed wounds, and non-compliance.
Now, PEP failure is a very major problem, and you should know clearly, because even professors are discussing, IAP is discussing more than 12 children have died. Every death it comes on the television. People are asked what went wrong. The vaccine is wrong. Something is wrong. May I ask you one simple question, Rose? Is pre-exposure, post-exposure prophylaxis 100% effective? What do you say? Rose, you are there?
Yes, sir.
Is it effective 100%?
According to WHO, it has written like 100% effective.
Effective. Now, the thing is that Dr. Joy Philip, one of my most important teachers, used to say that nothing is 100% in life and nothing is 100% in medicine. Therefore, that is what he used to teach us again and again. Now, let's go into this. This is a very important point, not from the exam point of view, you should know it. See, prompt exposure is effective in 100% of rabies. Where does it come? Summary of key points, WHO position paper 2088. Now the next point is, what does the purple book say? Prompt PP following severe exposure is expecting in 100% effective. However, delay in seeking PEP, improper wound care, unnoticed wounds, direct inoculation, lack of patient complaints, and vaccination schedule, among other factors, contribute to the PEP failure and subsequent death. But what does it mean? When you have a death, it means it is improper wound care, unnoticed wounds, direct nerve inoculation, lack of patient complaints, and with vaccine, among other factors. That means all these are your mistakes or the patient's mistakes. Therefore, immediately the thing happens that is your problem. Now, what has happened here? They have given this reference 21 WHO. Rose, you can go and check it in the internet. It is 21. That's the reference they give for a great statement. If I looked into that, Science Direct is a failure of post-exposure rabies prophylaxis. That is what is given. You go into it. Rose, can you read it?
It is likely that post-exposure rabies treatment failures are underreported. It was in 1996 and 1999 that we encountered the first case where apparently all WHO recommendations had been carefully followed by experienced staff. There was no evidence of lack of wound care, low potency or inadequate cold chain of the biologicals, and yet the patient died of rabies. We now present a series of 7 cases of what appeared to be true post-exposure prophylaxis failures. Each of these had what appeared prompt and appropriate wound care, were administered immunoglobulin of equine human rabies, 40 and 20 units respectively, and this was injected into and around the white wound. And these deaths suggest that even diligently done post-exposure prophylaxis may not be 100% effective in preventing rabies.
Yeah. Can you imagine in the WHO paper, which says 100% effective, the reference given is directly opposite to what they have written. Directly opposite. And then you may say that, you see, this is something which is wrong and all those things. You know, this is from the Infectious Disease Department Division Research, Faculty of Medicine, Thailand. You know what is Thailand? This was where the original research of the vaccine was done. If you look at it, the Thai guidelines, the vaccine schedule, etc., is there. Therefore, WHO's research facility, they have done this and they have found 7 or 8 mistakes. And the most funny thing is, this is what it is. Prompt severe exposure, 100% effective in rabies. They are given a reference which is directly opposite to what they have written. Therefore, remember, please understand, nothing is 100%. WHO states, PEP says, but the reference it gives is directly opposite to what we have seen. Now, keep it in mind, because don't accuse. But remember, the most important reason I see why these vaccine failures are happening is because probably, you should not blame them. Instead of intradermal, it is given subcutaneous. It's not that easy to give intradermal injection. Number 2, equine rabies immunoglobulin cannot be standardized. It's not easy to standardize it, unlike monoclonal antibody. So far, according to, there is no failure of rabies vaccination which has been given in the private sector where monoclonal antibodies have been used. But then, of course, you can say that private sector may be only 5% or 10%, and the bites may not be as severe as in the government sector. But definitely, these are points which you should remember. Okay, now go ahead, read fast. Faris, you can read.
What is the recommended site for intramuscular rabies vaccine administration in children? Anterior lateral thigh.
Okay. It's a D actually. Can you read it? Yeah.
Vaccine should be given in deltoid for more than or equal to 2 years and anterior lateral thigh all age. The gluteal region is contraindicated due to lower immunogenicity.
So that's what it is. Therefore, there's a beautiful failure. We have intramuscular injections and intradermal rabies vaccination, deltoid muscle for adults and children. And do not use gluteal region, anterolateral thigh for infants and small children. Up to 2 years anterolateral thigh. After that, you can give it at whatever age you want. But it may not be easy to give on the anterolateral thigh of a woman or something. You can give it in the deltoid. Okay, never in the gluteal region. Okay. Intralateral delta, rabies should never be injected into the gluteal region. That's okay. Now come next. Read it.
When should rabies immunoglobulin be infiltrated in a patient with multiple bites on the leg? A. Only if the child is immunocompromised. B. Into and around all wounds, even if a volume exceeds calculated dose. C. Only in large wounds. D. Not required if vaccine is given promptly. B.
Or else even if volume is exceeded, vague answer, the explanation. Volume is too. What do you mean by volume is too large? It can be diluted with saline. It should be the other way around. If the volume is too large, you don't dilute it. Yeah, maybe if it requires all the wounds, they want this to be diluted and given. Maybe that's what they are answering. Multiple wounds, you have only 3 ml with you. You have to. You must give it to each and every wound. That is the reason. And it says clearly that the remaining RIG should not be given IM. Rose, is it correct? Remaining IMG should not be given IM.
It can be given, sir.
Okay. All right. Read it. Okay, read it. That's also, see, so many points in your rabies vaccination are controversial. And here is Rose answering it can be given IM. What's the problem of giving IM? Why are we so insisting that it should be given round the site of the wound only? There are some difference and problem is there. I'm going into that. Why do we prefer to give it on the local site? Tetanus immunoglobulin, we give it intramuscularly. Why can't we give it intramuscularly? Why infiltrate the wound to Rose? Majida, can you answer Rose?
For neutralization of
Yeah.
uh,
Why don't you give it IM? It will also neutralize, isn't it?
the bioavailability at that site cannot be ensured if we are giving by IM.
All right. But you comes close to the answer. Faris or Majida, if you know you answer, can you know what's the reason?
Before entering the
Majida, because of lack of time, I will interfere because the most important point to remember in the rabies vaccination is the virus goes through the nerve. It enters the nerve, goes into the anterior cell, goes through the spinal cord, goes into the brain. The moment it enters the nerve, you have failed. You have failed. It is not through the bloodstream spread unless tetanus organism. It doesn't go into the bloodstream. Therefore, the local injury is very, very infiltration is the most important thing. Now, remember what the IAP guidebook on immunization is telling. Read it fast.
Administration. Rabies immunoglobulin or monoclonal antibody should be thoroughly infiltrated into and around the wound. For small wounds, the maximal quantity that is anatomically feasible should be administered. It is important to avoid the compartment syndrome, which occur if large volume of immunoglobulin is injected into a small body area with limited tissues. It is no longer recommended to give remaining part of immunoglobulin intramuscularly.
Rose, did you know it? This is the purple book of immunization. Don't be dejected. You are also right. We'll come into that. Okay. Okay, read it.
Therefore, Therefore, if the volume of the calculated immunoglobulin dose is likely to be too large for local wound infiltration, it can be fractionated into smaller individual syringes, and the residual unused immunoglobulin can be used the same day for other patients if stored and handled as aseptically. Unused fractionated immunoglobulin should be discarded at the end of the day. If the wound are large or multiples, the maximum calculated volume of immunoglobulin can be diluted with physiological buffer saline to allow sufficient volume to complete wound infiltration.
See, suppose it's a bad bite, means some small prick in the finger, or a small prick in the tip of the nose. How much can you infiltrate? Therefore, you will infiltrate small volume. What happens to the rest of the volume? What will you do? They say indirectly is telling throw it out. You understand? Indirectly. He doesn't say that you need give only partial dose, whatever you can. Because if you infiltrate too much in the finger, you can produce a compartment syndrome and you may have a gangrene. It need not be given IM according to IAP, but I would give it because you can't give locally. Therefore, it is very simple to say that you should infiltrate all the wounds. You should, even a small wound, you should infiltrate everything, and this IM dose is not effective. But definitely, you should try maximum to infiltrate on the wounds. That's the most important thing. Well, can you give it IM? According to IAP, no. The rest of the syringe you can use for somebody else or throw it off. Now we come to National Rabies Guideline, which we are binding on us. You understand? Okay, read it now.
The rabies immunoglobulin should be brought to room temperature, that is 25 to 30 degrees Celsius, before administering to the patients. The entire immunoglobulin dose, or as much as anatomically possible, but avoid possible compartment syndrome, should be infiltrated carefully into or as close as possible to the wounds or exposure site. Evidence suggests that injecting the remaining immunoglobulin volume intramuscularly at a distance from the wound provides little or no additional protection against the rabies as compared with the infiltration of the wound alone.
Remember that very carefully. He has written at the end of sentence, as compared with infiltration of the wound alone. Okay. Now come what he says. National guideline. Yeah.
If, however, there is high likelihood that there are additional small wounds. Example, if a child does not report all wounds, injection of remaining rabies immunoglobulin volume intramuscularly as close as possible to presumed exposure site to the degree that is anatomically feasible is indicated. The same applies to mucosal exposure with no wound, and rinsing with immunoglobulin can be considered. In the case of suspected exposure to rabies virus via aerosol, an intramuscular injection of rabies immunoglobulin is still recommended.
So therefore, Rose is right. Remember, previously in all our hospitals, they will give a little, they used to give only IM alone. Huge mistake. Previously, till recently, even in General Hospital Trivandrum, I came to know, I'm not sure whether it is right. They were giving half IM and half intrama in the local side. Again, a huge mistake. What you should do is try to give it as much as possible locally. If there are multiple huge wounds, dilute and make sure that every wound is given. Now, if a single wound is there, you're not able to infiltrate the whole volume into it. According to IAP, infiltrate, but directly does not say throughout the volume, but indirectly it indicates. But then what do you do with the rest of it? Give it IM, because national guidelines definitely says you can give IM. And for aerosol exposure, if suppose the child has been given a injection, in a mucosa, it has licked the mucosa, and there is a what you call tear inside the mucosa, then you will have to give it IM. Therefore, national guidelines does say, but it is not very scientifically correct. Now here, I think I would go through it before we go further into it. Remember here, this is the Ministry of, this is the national guidelines, Ministry of Health, Family Welfare, I think. Actually, it is in 2018, and they came about with what you call with a update on 2022. In the Indian Journal of Medicine, Community Medicine, they are very, very angry. They say this should only be followed. You have no right to follow this, but that's not right. Therefore, in WHO guidelines, there is no IM administration. And in residual volume, the RIG administration is there. Now, I will tell you one thing. Rose, do you know what's the fundamental difference between WHO guidelines and the Ministry of Health guidelines? Any idea?
The WHO focus on the entire population, sir.
Yeah, what's the difference actually in what do you follow in your hospital? Do you follow the WHO or do you follow the MOH? What's the difference? Is there a difference?
Ministry of MOHFW guidelines we are following.
Okay. Therefore, how many doses you give?
0, 3, 7, 14 and 28 single IM dose.
Very good. See, every dose, if you look through here, will be one dose more than the WHO. Now, if I will begin with the intramuscular dose, this is 303714, which Rose said. If you look at the WHO, it will be 037 and between 14 and 28. That means there are 4 doses. Here, there are 5 doses. Therefore, you better err on the side of this baby. But certain places, what they do is this is called a Sagram dose, 2 site MD IM on day 1, day 0. On one site 7 and 21. That is, this is an abridged version of this. Why does it say? Because compliance will be better. You are given 2 doses on day 1, and then you give it at 7. This is not followed usually, but the WHO says that. Now, intradermal is 0, 3, 7, and 28. Here's 0, 3, 14, and 28. There's 4 dose only in the intradermal, but 2 sites are given on the same day. We will come into that in later, but remember this, and almost you have to, if you want to know the guidelines, if you want to know what it is, this slide alone, you go very, very carefully and look at it. Now, everything MOH guideline will be 1 site, 1 dose more. But the only dose where both are same is when re-exposure is there. Intramuscular dose 0.3, here also is 0.3. Intradermal 0.3, here also 0.3. Re-exposure, both are same. Pre-exposure, post-exposure, WHO guideline, our national guidelines is 1 dose more than what the WHO guideline says. And the national guidelines talks about residual volume IM at distant site. It doesn't say. Come, let's give it. Okay. Can you read it?
Which of the following is true about the rabies vaccine?
Yes.
It is a 5-dose IM schedule. B, licensed for use in children less than 18 years. C, recommended nanoparticle based given on day 037 requires a reconstitution before use.
It's a new rabies vaccine, the rabies vaccine. It will come to you. May not have read it. If you have read it, read the explanation. Answer is C. Can you read the explanation?
The rabies candida. It is a 3-dose IM vaccine. Day 037, licensed for more than 18 years. Does not require a reconstitution, and it is less painful. Not yet endorsed by IAP or national Control for Disease.
National Center for Disease Control, I think, is the United States. Remember, this may be available in the market. Twin Rab is available, Rabies Shield is available, TH Rab is available. Therefore, in the ER, they may be giving it to patients above 18 years because they require only 3 doses. Therefore, but you cannot give it in pediatrics. Remember this. The full, better know it, not from the examination point of view, from the practical. Read it very fast.
Reduced 3-dose schedule TH Rabies. Candila Pharmaceutical has developed a novel 3-dose recommended nanoparticle-based rabies G protein vaccine, TH Rabies, based on virus-like particles technology. The vaccine generates antibodies against the rabies G protein, which leads to virus neutralization and prevent virus attachment to the cells to confer protection against rabies. Candila Pharmaceuticals successfully tested immunogenicity and safety of 3-dose, that is 50 microgram on day 037 of novel vaccine in phase 1, 2 and phase 3 clinical trials in healthy volunteers as well as preclinical models. The safety and immunogenicity of the vaccine were established in the trial. TH Rabies is an intramuscular vaccine and is less painful for the recipient and does not require reconstitution prior to use. Since it is a 3-dose vaccine, it will improve compliance to complete the vaccine course. This vaccine has been licensed by the Drug Controller General of India for use of more than 18 years of age. However, NCDC, WHO, IAP have not made any statement on use of this vaccine.
Okay, therefore that's an important thing. Anyway, don't use it. That's it. Okay, read it now.
A child on hydrochloroquine for lupus needs rabies post-exposure prophylaxis. What is the recommendations? A. Avoid intradermal route due to reduced immunogenicity. B. Avoid IM route. C. Contraindicated. D. Delay pre-exposure prophylaxis until drug is stopped.
What do you say?
Avoid.
Any ideas? You're not seeing the slides then, okay? Rose, you want to help?
Yes, sir.
What is it?
Sir, not sure, sir.
Okay. Therefore, read it.
Option A. Avoid.
Yeah. Paris, you read it. I'll give it to Rose after 15. You read it.
Avoid intradermal due to reduced immunogenicity. Chloroquine, hydrochloroquine may reduce
DNA titers, viral neutralization antibody titers with ID vaccination. Remember that for immunosuppressed patients, intradermal injection is not recommended. Okay. Yeah.
Post-exposure prophylaxis is not contraindicated. If possible, complete pre-exposure prophylaxis before starting the steps.
Okay. See, there's no contraindication. You cannot postpone because you will die. No mention avoiding ID routine paper and WHO position paper. It seems they have written WHO was the wrong answer, but let me go through it. I will read it fast. Difference of 0.5. There's no contra. Here I am writing. Receiving treatment with chloroquine, hydrochloroquine, both ID and IM routes of vaccine can be used. Therefore, they are given a wrong answer here. Sorry for that. Anyway, this is why I'm just showing it to you. Some of the MCQs are the best way to test because they give you a in-depth of the knowledge. But some MCQs are really wrong also, as we find here. Okay, now go to the next one.
Which of the following is a WHO category 2 exposure? A. Lick on intact skin. B. Minor scratch without bleeding. C. Bite with bleeding. D. Lick on mucous membrane. B. Minor scratch without bleeding.
What about lick on intact skin? It will be great.
Category 1.
Yeah. Okay, we have seen it already and we have seen this already. Category 1. and licks on intact skin are considered as this one. We have all these seen. Now, this is given regional aspects. They have brought about a new one. Only thing is, remember, I wanted to present this. See, single contamination of mucous membrane with saliva, licks, is category 3. Remember, when a child, they have not written broken mucous membrane. They have just written contamination of mucous membrane with saliva. Now, what happens if a dog kisses a child? Naturally, the saliva goes inside the mouth of the child and he swallows it. Therefore, that is a huge problem. Therefore, it becomes 3. But at the same time, here, in the lick on intact skin is considered as stage 1. And lick on mucous membrane, even if it is intact, is considered as category 3. A mistake here can be fatal. Remember this. I don't know whether you knew it. I didn't know it. I was surprised. That's why I undergone it. And there's another problem here. Minor scratches, abrasion without bleeding. What is bleeding? Remember, most of the patients will have an erythema. That erythema is not bleeding. Some people say oozing of blood. Some people say even a drop of blood is category 3. Err on the side of category 3. Okay. Go ahead.
A
Faris.
newborn bitten by dogs. Which of the following is true? A. Post-exposure prophylaxis is contraindicated in neonates. B. Only vaccine should be given. C. Full post-exposure prophylaxis with vaccine and rabies immunoglobulin is indicated. D. Observation of growth is sufficient.
The question is a little vague because they are not written whether it is category 3 bite. They're just written is bitten by a dog. That's all. What do you think is the answer?
Full
PEP, yes. Answer is C. Full PEP in neonates. No contraindication of PEP in infants, neonates, pregnant women. Category 3 exposure. IAP guidebook. Here also, the IAP doesn't say neonates. It says lethal disease, no contraindication in infants, pregnant, and lactating women. Infants might require newborn also. Therefore, that's why in MCQ, a little alteration in the wording it puts you in doubt. Anyway, what's the average? Now, Rose, you read it now.
What is the average incubation period of rabies? 30 to 90.
Yeah, 30 to 90 days is the usual. Remember, the problem here is very important to remember. Every point in rabies is important. It can range from less than 7 days to more than 1 year. I have read that it can be up to 5 years. You understand? More than a year. It can be less than 7 days. That's why we are giving immunoglobulin rushing. It can be more than 1 year. It can be up to 5 years. And I have read, but I didn't get it in this time. What is the significance of it? It will come now. Therefore, hydrophobia, there are 2 forms of rabies anyway. Clinical symptom average is 30 to 90 days. 3 months, that's when it happens. Okay. In the incubation period, usually averages 4 to 6 weeks, but can range from 5 to 6 years. That is given in IAP immunization book, okay, 2018. When it came to 2022, they didn't give it. Okay, this is how it happens. Now, the incubation period from 5 days to several years, usually 2 to 3 months, rarely more than a year, depending on the amount of virus inoculant, density of motor endoplace, and the proximity of the virus and central nervous system. Reference WHO expert. The incubation majority 1 to 3 months. Again, now 2018, they say majority 1 to 3 months. What is important here is it can be more than a year. And it is world. What is the significance of it? It will come out as we go along. But incubation period is average 4 to 6 weeks, but 5 days to 6 years, according to them. Therefore, what is the significance of it? Read what is given in the bracket. Okay.
Persons presenting several days or months or years after the bite should be managed in a similar manner as a person who has been bitten recently if rabies immunoglobulin is indicated, as rabies may have a long incubation period and the window of opportunity for prevention remains.
See, very, very important. See, what happens 6 months later, 7 months later, a mother may suddenly bring the child and say, Doctor, I'm worried. Why are you worried? The neighboring child died of rabies. My child was bitten by the same dog. It was a pet dog. Anyway, my child is okay, but he had multiple bites on the leg and everything. And I had not given immunization, or I was not there. Now, my question here is 6 months have elapsed. Will you give the vaccine? Yes, we have already seen it. Will you give immunoglobulin, Rose?
Yes, sir.
Okay. Now, if you give tetanus prophylaxis, will you give tetanus vaccine to this child?
If it's within 5 years, the child has received.
Oh, yeah, we have gone through it. Any deep wound, this WHO does not talk about this 5-year, 10-year business. We have gone through it anyway. IAP and others say that 5-year, 10-year business is there. But anyway, if the child is deep and bad wounds, you better give the tetanus toxoid according to WHO. That's one thing. Now you will give rabies immunoglobulin, is it not? Because you don't know. Right? Or you will not give?
Will give, sir.
Will give. What about tetanus immunoglobulin? I'm asking you
No.
huh?
Tetanus immunoglobulin will not be given.
How long after an injury when you give tetanus immunoglobulin? There's a bite by a rabid dog. He comes after 8 days, multiple wounds on the. He's coming from the top of the forest or somewhere very deep in the rural area. How long you have to give tetanus, you have to give rabies, you have to give rabies immunoglobulin. Should you give tetanus immunoglobulin on the 10th day? Again, a life and death issue, Dr. Rose. Well, when we put up if you look at the video, we have already mentioned it up to 21 days. Therefore, up to 21 days. Rabies immunoglobulin for years, you'll have to give it. Okay, now now read it.
Which of the following is not a recommended component of wound care? Irrigation with soap and water for 15 minutes, irrigation with 70% alcohol, use of Dettol without rinsing of soap, debridement of devitalized tissue. Debridement of devitalized tissue.
Is not recommended.
Not recommended.
Suturing is not recommended. Debridement is indicated. Okay. Read this.
Dettol quaternary ammonium compound is inactivated by soap. Soap must be washed off before applying Dettol. Alcohol and povidone are effective.
Therefore, this is wound care. This is in the World Health Organization. Wash 15 minutes. 15 minutes is a long time. Irrigation with 70% alcohol, povidone and quaternary ammonium compound. Dettol gets inactivated soap. Trace of soap must be washed off before use. Very important. What about suturing? Will you do it or not?
It will be delayed suturing only.
Delayed. Suppose, when do you do the suturing? The surgeon will say, I have to do because there's bleeding, doctor. There's bleeding. He's bleeding. How can I stop the suturing? What will you do?
If there is no emergency, then recommended
There
after
is an
72
emergency. He's
hours.
bleeding. How can you leave it like that? He's
Administer
losing.
immunoglobulin.
Yeah, that is the answer. When suturing is unavoidable for purposes of hemostasis, it must be ensured that rabies immunoglobulin. Before he sutures, you say, no, wait, and you go and inject the site with immunoglobulin. Surgeon will not be happy, and then you have to think of this. Remember, this is very, very important. Washing for 15 minutes. It's a long time in running water. That's the most important thing they say. Okay. 50% viral load will be decreased. And each one of this washing running water, mechanical removal from the wound. When you give soap and water and apply antiseptic, inactivation of the virus. And when you give the locally infiltrate, neutralization of the virus. Okay, remember one thing, all of you, do not touch the wound with a bare hand. Why I'm asking you this is there is no human to human transmission. But remember, if you have a cut in your wound, cut in your finger, anywhere, scratch and a skin has gone out, it can be dangerous. Therefore, always wear a gloves before you look after a child. But don't be don't show fear. If you show fear, the nurses will also not do it. Okay, now we go ahead with it.
A
Yeah, good. Yeah.
child received ECG, but it was given intramuscularly instead of infiltrating the wound. What is the implication? No effect, increased risk of anaphylaxis, reduced efficacy of post-exposure prophylaxis. Option C is
Yeah, that's the right answer. Ashen serum infiltrating the wound neutralize well. IM administration alone ineffective and increases what they're given, reduce efficacy of PEP. No effect may also be doubtful because if you give what is given goes through the nerve, you are giving IM. How can it be effective? It cannot be effective. But anyway, RIG is infiltrated in and around the wound. Okay, now next question. If, however, there's a likely, we have already seen this. The national guideline says if, however, the likelihood that additional small wounds of a injection remaining intramuscularly as close as possible site to the degree which is anatomically feasible is indicated. Only the national guideline says that. Okay. What does the national guideline say? Can you read it now? Fast.
administration of rabies immunoglobulin. The rabies immunoglobulin should be brought to room temperature 25 to 30 degrees Celsius before administering to patient. The entire
Yeah, okay, doctor. I think we have read it already. Okay, therefore I will go through it. We read this already once. Okay. No longer recommended according to IAP, recommended by the WHO, by the National Rabies Guideline. Okay, that is, we have already read it. Therefore, I am not going to go through it again. Now, this is how you infiltrate. Okay, T8 delay. How you infiltrate intradermally. This is the way you infiltrate intradermally. Here, you are infiltrating the wound. Okay, you are infiltrating the wound. That's okay. Where residual volume is distant side. What's a post-vaccination serological testing indicated? Now, Rose, you read it.
when is post-vaccination serological testing indicated? In all children after PAP, only if exposed to bad rabies in immunocompromised patients routinely at 6 months.
What's that?
Immunocompromised patients.
Immunocompromised patients. Okay. Read that. Yeah.
Serology is not routine, indicated in immunocompromised, significant schedule deviation or occupational exposure.
Very important to know it because in immunocompromised patient, you do the serology and it comes again low. What will you do? Read it now. Read the
Tighter post-vaccination serological testing, routine estimation of serological response following the completion of pre-exposure or post-exposure prophylaxis is not necessary. It is necessary if the person is immunocompromised, significant deviation of prophylaxis schedule have occurred, the person's antibody status is being monitored routinely due to occupational exposure to rabies virus. It is desirable to monitor antibody titers every 6 months in those with continuous exposure and every year in those with frequent exposures. A booster is recommended if the antibody levels falls below 0.5 international units per ml. And when serology testing is not available, booster vaccination every 5 years is an acceptable alternative. For re-exposure at any point of time after completed pre-exposure prophylaxis or post-exposure prophylaxis, 2 doses are given at 0 and 3. Rabies immunoglobulin is not rabies immunoglobulin should not be used as it may inhibit the relative strength and rapidity of an expected anamnestic response.
Should not be used. You understand that? It's a very important point. I didn't realize it, but still I read it. Okay. RIG should not be. Remember certain things. You cannot make a mistake in this again. If you have a dog catcher, nowadays they go for, you will have to tell them to do the antibody titers. If it is not possible, then he has to be given a booster vaccination every 5 years. And what is that booster vaccination? Probably it is 0.3 dose. Remember, when you have a re-exposure, you give 0 and 3. For pre-exposure, you give 0 and 7. Okay, subtle differences you should know. Now, antibody status, if you have immunosuppressed, suppose he's a nephrotic syndrome, you have given him, he is bitten by a dog, Kunin male kuru. If he's bitten by a dog, you will have to give him rabies vaccination, but insist on having the antibody titer done. These are things which, as a pediatrician, you are expected to know. Okay. Okay.
Get
Yeah.
exposure prophylaxis but miss the days and
I can't hear you.
presented on day 10, what should be done?
Okay.
Give the day 7 dose on day 10 and continue on day 17 and 31.
All right. You read what is given.
Resume as if on the schedule, give the missed dose and maintain the intervals. No need to restart.
Okay, interval should be maintained, but you know what dose did he give about? I am not sure. This is because he has copied and pasted from the immunization book. It says that can you read what is given in the bracket?
If a patient missed the dose scheduled on day 7 and presented for vaccination on day 10, the day 7 dose should be administered on that day and the schedule is resumed, maintaining the same interval between the dose. In this scenario, the remaining doses should be administered on day 17 and 31.
I don't understand what schedule they followed because see, if you look at the national guidelines, I think they are talking about the intramuscular dose. She missed the 7th dose and came on the 10th day. 3 days missed. Therefore, they have to give it on day 13, is it not? Day 14, I think. And the 14th dose will have to be given on 21st and the 28th. But that's not what is given here. What is given here is 7 presents on day 10, should be administered on day 10. In this scenario, 17. How come it became 17? Because 7 and 14 is 10 day, 7 day, for 17. And then 14 and 28 is 2 weeks actually. You gave on 17 and then you gave 31. 14 and 21, there is 13 days difference, isn't it? 14 days difference. Yeah, it's right. Maintaining at same interval. Therefore, they are talking of this regime. They are talking of this. That is the 5-dose regime of prophylaxis. Maintain the same interval and then give it. Okay. That is, anyway, the 5-dose regime is known as what it is: 0, 3, 7, 14, and 28. Schedules you must know. And 0, 3, 7, 14, and 28. This is the National Rabies Guideline. 5 doses, 5 visits, 1 IM dose. Therefore, remember that even the national guidelines advises IM, but prefers. But if you can give only monoclonal antibody, I mean, if you can give only intradermal, it also advises that. But the standard it advises is 5-dose IM dose. It's called the ESSEN schedule, ESSEN schedule. Okay, read it. I think, yeah. Where is we read? I can't hear.
Which monoclonal antibody targets antigenic site 3 on the rabies G protein? In rabies.
You have any opinion, Majida? Antigen 3 is supposed to be rabies shield, targets antigenic serum 3, crucial for viral entry. Between the 2 different epitopes, but not specifically type 3. That's the difference. You know, epitope means, what is an epitope? The part of an antigen to which the antibody attaches. There will be multiple epitopes in an antigen. The rabies shield, this is antigen site 3 on rabies G protein. Anyway, can you read it?
Rabies antibody has been shown to neutralize a broad panel of properly preventable rabies virus isolates. Its neutralizing activity has been mapped to antigenic site 3 of the rabies virus G protein, a region crucial for viral receptor binding and dissemination.
I want to
However,
our 1 minute, doctor. I'll read the rest of it very fast. Remember that this is a very important article from Efficacy and Safety of Monoclonal Pep Rabies, August 9th, 2025. That means we are in September, 1 month ago, from the most famous journal, that's Lancet. Okay. Now, there is a huge issue here in India. They say that the monoclonal antibody may not cover all the rabies virus in Kerala, in India. Therefore, escape mutants are known, but it is usually North American bat population. Remember this. And bats are not supposed to be important there. Therefore, as far as we are concerned, it should complete everything. Therefore, it's here also the IAP guidebook also says that's the ectoderm of G glycoprotein. And if you remember I'm going a little fast because we are falling behind schedule. This is the G protein. This is the bullet-shaped virus, This is the M protein. This is the nuclear protein, the rabies virus. The G protein is here. It is that which it targets. Now, twin rab is a combination of two murine monoclonal antibodies. They bind to two different epitopes on the G protein. It's not on the same epitope. It's a different epitope expressed. The two monoclonal antibodies bind to, therefore, because it binds to two different, it has a broader spectrum. TwinRab is also available now in the market. That's why I'm telling you. Okay, now you go through the.
what is the primary advantage of monoclonal antibody over rabies immunoglobulins? A lower cost, B no need for skin test, B higher volume requirement, D animal derived.
Okay, what is it?
No skin test.
Yeah. Yeah. MBB does not require skin testing unless ARIG, and they are recombinant, avoiding blood-borne pathogens, ensuring blood consistency. Majida, may I ask you, Faris, you have worked in health center before you came here, is it? Or you worked somewhere else? Before they gave the equine rabies immunoglobulin, do they do a skin test? They do or they don't do? Should you do or should you not do?
We should do.
WHO says no. They say that even that skin test, whether it's positive or negative, you will have to give it. Be prepared to treat anaphylaxis. That's what they say. But what is followed is skin test is done. And many people on skin test develop severe reaction according to few community doctors who are coming here. Therefore, what's the advantage of monoclonal antibody? No skin test, not a blood product. Therefore, you won't get hepatitis B or C. Batch to batch, the potency is same, unlike the Equinoceras, and easy to production in a multiple way. Here, no animals are involved. In fact, in Western countries, equine rabies immunoglobulin is not allowed because of animal rights protest. Therefore, all this is advantage. Even then, the national guidelines and our doctors come and say that monoclonal antibody does not cover all epitopes. Anyway, remember what is given here now. Carefully read it. I'm re-emphasizing. I'll read it. I think Majida, you read it fast. Majida, yeah.
Rabies human monoclonal antibody. In view of the irregular availability and high cost of rabies immunoglobulin, ACVIP endorses the use of RH-MAB as an alternative to rabies immunoglobulin, human or equine, along with rabies vaccines in all category 3 bites.
Okay.
This newly introduced monoclonal antibody has emerged as a safe and potent alternative to rabies immunoglobulin. The WHO position paper on rabies in 2018 has also suggested encouragement of use of these products if available instead of rabies immunoglobulin. The comparative advantages include easy availability, standardized production quality, possibly greater effectiveness, no requirement of animals in its production, and less adverse events.
Okay, this is by the Indian Academy of Pediatric Advisory Committee. Okay, 40,000 to 50,000 pediatricians are involved. Therefore, you have the right to go against the national guidelines. That's what I feel. Last sentence is very, very important. What is given here?
Recommendation for monoclonal antibodies. ACYP strongly recommends the use of monoclonal rabies antibodies over rabies immunoglobulins in the management of category 3.
Therefore, whenever anybody asks you, how can you go against the national guidelines, we don't go. But we have so much evidence that if your primary concern is to the patient, you should use the monoclonal antibody, whatever anybody might tell you. Okay, this is coverage that it covers only certain epitopes are not right. The Lancet article on August 2025 has said it covers almost all the epitopes except certain North American bats. There is an article very recently published from the Indian from Manipal, again in Lancet. I forgot to quote it here because I didn't get the time to put it. Again, it says in the South Indian population, this Rabies shield monoclonal antibody covers. They have done it with Serum Institute, and they have found out that it's quite effective. It covers all the epitopes. Okay, now go ahead.
A dog that bit a child is healthy and can be observed. After 10 days, it remains healthy. What should be done? Stop post-exposure prophylaxis immediately. Continue full PEP. Complete only 3 doses of vaccine. Stop further doses if one isn't scheduled or as exposure was non-infectious.
What do you say? See, you started a dose 037 you have given already. The mother comes and says the child is healthy. It was doctor, my neighbor's dog. The dog is alive on day 10. What should I do? There is a dose remaining at 14. There's a dose remaining at 20. Rose, what will you do?
It can stop further doses if one isn't
Yeah,
scheduled.
then it becomes a pre-exposure prophylaxis explanation. Okay, read it.
If the dog remained healthy for 10 days, it was not rabid. In essence, schedule day 14 and 28 doses can be omitted.
Previously, we used to observe the dog for 10 days. If it is alive, no vaccination. Now, no observation. We start the vaccination. But if it is alive on day 10, we stop the vaccination. Therefore, it becomes a pre-exposure, this one. Okay. Let me see one thing.
Vaccination.
Now, the next question here is, it often happens that you're bitten by a pet. You understand? You have a dog at home and it normally never bites. For some reason, it bit the child. And the dog is immunized. Therefore, what will you tell Majida to the parent? Should the child take the vaccine or not?
It should take the vaccine, sir.
Then why vaccinate the dog? What do you say, Rose?
Vaccinate the child, sir, because the antibody, the levels in the animal cannot be assessed.
All right. They follow the. Now here is a problem. Now read through it. Okay.
Animal vaccine failures may occur because of improper administration, inadequate doses, poor quality of the vaccine, or poor health status of the animal. Thus, the history of rabies vaccination in animal does not guarantee that the biting animal is not rabid.
Okay. Now next.
Therefore, in the absence of laboratory documentation of immunization, that is antibody titer, it cannot be presumed that a vaccinated dog is actually protected given the variable efficacy of various anti-rabies vaccine in animals or health status of animals. Hence, irrespective of the vaccination status of the biting animal, the PEP should be given. The treatment may be modified if dog or cat involved remains healthy throughout the observation period of 10 days by converting PEP into pre-exposure vaccination by skipping the vaccine dose on day 14 and administering it on day 28 while using essential schedule.
I don't know why they should give it on day 18. I didn't understand that. Anyway, see, day 28, why you stop it, is it not? Why skip it? And remember, this is the national guidelines. It's very important for you to know because the veterinary doctors will be very angry because they will say, we have given vaccination. Why in the hell are you creating problem for us? Then what's the point in us giving vaccination? Tell them that the national guideline says they are not happy with the variable efficacy of the anti-rabies vaccine. See, remember, these vaccines are sanctioned by the government, and the same government is telling the efficacy may not be correct. Therefore, we are fully justified in giving it in India. Is it the same in Western countries? Okay, read it. This is Western country. Yeah, okay, read it now.
In case of bites by pet animals, PEP may be deferred only if the pet at the origin of exposure is more than a year old and has a vaccination certificate indicating that it has received at least 2 doses of a potent vaccine, the first not earlier than 3 months of age and the second within 6 to 12 months of the first dose and in the past 1 year. If vaccination is deferred, the pet should be observed for 10 days. If the dog shows any signs of illness, during the observation period, the patient should receive full rabies post-exposure prophylaxis.
This was given in the IAP guidebook, that is the pink book of 2018 and 19. They copied and pasted from the Western literature. Okay, this is what happens in America and all. If the patient is given immunization, the dog is a pet animal given immunization. That is the first dose not earlier than 3 months, the second dose within 6 and 12 months. And in the past year, 1 year has not elapsed since the last vaccination, and it is documented. You can observe. That is what? That was given in 2018 and 19. Rose, have you read 2022? What does it say? Any one of you? It's a very important medical legally. National guideline says give. What does 2022 IAP guideline says? Why did I quote it from 2019 and not from 2022? Okay, it can be deferred according to that. Okay. In the 2022, I went from page to page. They don't discuss it at all. Such an important thing. They should have written, we follow the national guide. No, they have not opened their mouth on it. This is very bad because you are supposed to give, because they have written like this, people would defer it. No, pet dog, you should give. Purple book does not answer. This is an old edition. This is what is followed in Western literature, but not so in India. Okay. See, this is from the up to date in August 2025. I've written. Read it. What is given here in the United States.
Decisions about prophylaxis can often be delayed if the animal is a healthy dog,
Healthy dog,
cat,
a ferret. Can't read it. Yeah,
ferret, and is able to be confined and observed for 10 days.
What do you mean by healthy? I don't know. What is vaccinated is already we have said. Therefore, this is what is happening in the Western countries. This is what is sent in IAP Guidebook 2019. Tactfully, they did not talk about it in 2022, but we have to follow the national guidelines. Be very clear in this. Okay. All right. Now go ahead.
Which of the following is a reason to avoid suturing a rabies bite wound? Risk of infection may trap virus and prevent rabies immunoglobulin infiltration. Cosmetic concern, delay in vaccine response. May trap virus and prevent rabies immunoglobulin.
Okay, that's we have already seen it. Okay, they may trap the infection. We have gone through this. Any suturing a wound should be avoided. When suturing is unavoidable purpose, it must be ensured you first infiltrate the RIG. Now, next question.
What percentage of rabies exposure are category 3? More than 90%.
Yeah, and so the answer also came in that. Okay, answer is C. Okay, this vaccine is 79. Answer also okay. Okay, therefore that is given in the. Remember that most of the exposure there will be some blood. If the dog is bitten, definitely it will cause some blood variation. Therefore, contamination mucous membrane saliva and more than 90% exposures are category 3. Any wound where a drop of blood is seen, it becomes category 3. Oozing of blood is not required. It requires only then category 3, bites by unknown animals. Remember this, bite by wild animals according to national guidelines. Unknown animals also. Therefore, a person walks out, he comes back and says, something bit me. I don't know. Rabies vaccination. Bite by wild animals. By you go trekking in the forest or an area, bitten by a rat there. Rodents, domestic rodents, no. Wild rodents, yes. See how many times you can make a mistake. That's what I am trying to make you. Okay.
Which of the following is true about pre-exposure prophylaxis in children? A. Routinely recommended for all Indian children. B. Recommended for high-risk children after parental discussion. C. Not recommended in India. D. Requires 5 doses. Recommended for high-risk children after parental discussion.
Yeah, there was a big talk in IAP. I don't know, because after 12 or 13 days, the Indian Academy of Pediatrics, I think, has recommended to the Kerala chapters, recommended to the Kerala government to give it to all children, because it's horrible. These deaths are horrible. And it has not been accepted. It's not a policy. But if you are practicing in a village and there are a lot of stray dogs there, better advise them prep in this one. Okay. That's the IAP guidebook. Now, next question. Read it.
Pre-exposure prophylaxis. Most Indian children are at risk for rabies. Therefore, Advisory Committee on Vaccine and Immunization Practice recommends offering pre-exposure prophylaxis to children at high risk of rabies exposure after discussion with the parents.
Now, if you have a dog at home, it is important to vaccinate the dog, but more important to vaccinate the children and others there, because you can get rabies from your pet dog also. I would say this. Voluntary basis. That's what we said already. Okay. What's the recommended schedule for PrEP?
0 and 7.
Very good. 0 and 7. For post re-exposure is 0 and 3, 0 and 7. But for everything will be 2-dose PrEP. 0 and national guidelines still recommends 3 doses. Okay. If you look at pre-exposure, intramuscular, 0, 7, and then 1 at 21 or 28. 3 doses, not 5 doses. That's what the national guidelines say. Therefore, what should you give? I would give the national guidelines. Okay. Here, I would follow the national guidelines because I don't want to be accused of anything. Here, intradermal 0.7 to 28. Intradermal also 2 doses only according to the WHO guideline. I'm telling you, re-exposure is same, 0 and 3. This slide, if you keep it in your mind, you will know the difference. And what says told in the IAP meetings, follow the national guidelines. We cannot follow for residual IM. We cannot follow the immunoglobulin, but we will give monoclonal antibody. Okay.
A child received post-exposure prophylaxis 8 months ago and is re-exposed. What is the management? Option A, full PEP with the immunoglobulin and vaccine. Option B, 2 doses of vaccine on day 0, 3 and no rabies immunoglobulin. C, wound care only. D, single booster dose. 2 doses of vaccines on day 0 and 3 and no immunoglobulin.
Oh, very good. Why don't you give immunoglobulin? Doctor, let's give. I'm worried. I'm worried. The mother. Give it, doctor. Give it. Give it on the local site. Why you're not giving? What will you say? Will you err on the side of caution? No, your immunoglobulin will neutralize the vaccine efficacy. That's why you don't want to give it. Okay. Remember that. Okay. This is re-exposure. We have already discussed it. All right. I'm not going into it. Therefore, in the end of the day, you must remember endorses new ACVAP endorses the new schedule, less schedule suggested by WHO. Therefore, now I told you I will follow the national guidelines. I will still follow it. It recommends one-site vaccination 0.7 for intramuscular injection pre-exposure, while the 3-dose 0.7 and a booster 21-28 by the national rabies guideline, which were endorsed in 2022 by WHO, by the national guidelines again. Therefore, I would follow this, okay? But ACVIP recommends only 2 doses. It's up to you. I would say err on the side of caution here. We have already seen this. Okay, go ahead.
Which of the following is a potential cause of compartment syndrome in rabies PEP? A, excessive immunoglobulin infiltration in small area. IM vaccine in deltoid. C, use of monoclonal antibodies. D, delayed PEP. A, excessive rabies immunoglobulin infiltration in small area.
Okay. Read it.
For small wounds, the maximal quantity that is anatomically feasible should be administered. It is important to avoid the compartment syndrome, which occurs if large volume of rabies immunoglobulin are injected into a small body area with limited tissue. If it is no longer recommended to give the remaining part of rabies immunoglobulin intramuscularly.
So for you, you'll have to throw away the remaining immunoglobulin if you can't give it. Will you do it or not do it, Rose? What will you do? Faris, you are going to a health center. You are going to be the CMO there. The poor Amal is now CMO. He's going to give in a finger bite point. The total dose to be given is 5 ml. He gives 2 ml and he fears that there'll be a compartment syndrome. What will you do to the rest of 3 ml? Faris, are you there?
Yes, sir.
What will you do?
Give us,
Huh?
give us IM.
He's no longer recommended to give the remaining part of RIG in Ramadan. Rose, what will you do? Rose, you are there?
Give us IM, sir.
Yeah, we follow the national guidelines. We are patriotic in that. Actually, that's for self-protection. We don't want to be. See, if you don't give it and the child develops immunization, this one, you go to a court and the judge just throws the paper down. Doctor, this is national guidelines. Have you read it? Yes. Is it not binding on you? It is. Will you not give it? You have to give it. But in monoclonal antibody, probably I will go against it. Okay. Now 30.
What is the recommended action of rabies immunoglobulin is unavailable? A, do not give any passive immunization. B, give double dose of vaccine. C, proceed with vaccine only and source rabies immunoglobulin later. D, use monoclonal antibodies if available. Use monoclonal antibodies if
Yeah, that should be the one
available.
which is preferred. I don't know why he says unavailable. Even if it is available, I'll give the monoclonal antibody. Anyway, and doses, we have seen all this. Okay, now recommended monoclonal antibodies. If RIG is not available, there's a very funny statement which is not given anywhere else. Rabies immunoglobulin is not available, then 2 doses of the rabies vaccine may be given on day 1. This, however, not so. This is one sentence is given in the IAP Purple Book like this. But I don't think that is a very correct statement. But it is given. There's no doubt about it. And if you are given vaccine, suppose the immunoglobulin is available after day 5, can you give it?
Yes, sir.
Majida?
Yes, sir.
It's available on day 8. Can you give it?
No.
Yes.
No. After day 7, you can't give it. Okay. Now read it.
Which of the following is true about rabies shield? Requires skin test, be derived from human plasma, C neutralizes all Indian rabies isolate, D dosed at 20 international unit per kg. It neutralizes all Indian rabies.
Isolates. You see, this is what the people will contention. I'll tell you what it is. The answer is right. Human Mount neutralize all Indian rabies. IAP Guidebook 2022. It has not made a statement like this. If I went to rabies into the rabies and neutralized 25 different wild type or street AB isolates, it doesn't say all the Indian. Now coming to anyway, then it has written here most promising antibody identified neutralizes all the rabies antibody isolates tested. What they tested, it isolates. Whether it will neutralize everything Indian isolates is not given. But then this is what I said, efficacy of monoclonal antibody for rabies, Lancet article 1 month ago. Studies in India have shown that the amino acid residues in rabies glycoprotein nursery for neutralization by rabies monoclonal antibody that of Serum Institute are conserved across all rabies isolates in interstitial animals. Therefore, there is a study in India clearly. These findings suggest that single monoclonal antibody could be sufficient for post-exposure in regions where rabies cases are predominantly caused by these isolates. Here is clearly written South Indian, okay? Serum in rabies glycoprotein neutralization, South studies in India, okay? Studies in India. Studies, and this has been produced in the Lancet article 1 month ago. Therefore, when you go for a meeting, when the lab says don't use monoclonal antibody because it does not cover all the epitopes in India, stand up and say, no, sir, the monoclonal antibody does cover. And monoclonal antibody shown to neutralize broad planet of prevalent virus isolate, neutralizing activity mapped to antigenic 3 of the region crucial for binding and dissemination. However, escape mutants are present in North American bat population. Is present in the North America. There was a study from Manipal, I think, published in Lancet, and there's an editorial on that. Okay, it's not something very small. See, they say that although monoclonal antibody PEP is encouraged, regional viral diversity and epidemiological context must be considered and might require use of at least 2 monoclonal antibodies targeting distinct antigen size or G protein to increase the breadth of rabies virus as indicated by WHO. That means in better than rabies shield, twin rabo may be twin rabies. That's what may be better. Although Kulkarni and colleagues provide crucial real-world data supporting the WHO endorsed shift to monoclonal antibody. WHO also says shift in monoclonal antibody, passive immunization, local infantry abbreviating vaccine schedule for rabies PEP. Therefore, remember that all the evidence is for rabies shield is a single, but twin rab may be slightly better. Okay. Read it.
A child with HIV is exposed to rabies. What is the PEP recommendation? Same as immunocompetent, double dose of vaccine. Option C, avoid rabies immunoglobulin. Option D, test antibody titers after post-exposure prophylaxis.
What's the answer?
Test the titers.
Yeah, very good. You have all become very intelligent. Post-vaccination serology confirmed response. PEMS is otherwise the same. HIV also, okay? This person is immunosuppressed. You have to check the antibody titer. We have seen it.
Which schedule is not recommended by WHO 2018 for post-exposure prophylaxis? SN schedule day 037 1428, 2 site intradermal day 037. Then
Which one? It may be a difficult question, I'm sure. They are given the answer endosses SN and 2 site Zagreb 211. Endosses SN and 2 site Zagreb, that's 211. What do you mean by 211 is on the day 1 you give 2 doses IM And this 7, you give 1 dose and 20. That is to decrease the number of this one for PEP and immunocompromised high-risk population. Therefore, the others, they all endorse 2-site ED, and even the SN, it endorses, it seems. WHO 037. This is SN has got 5 doses. WHO only advises 4 doses. Okay. But it endorses it, it seems. That's what I understood from it. All right. But the 2 dose, this is what was given when I was in Gulf. They used to give this Agrip. The first day they will give 2 injections. If you ask them why, they'll say, doctor, they may not come back. Okay. Therefore, it will become 0, 3 is not there, 7 and 21. Okay. That is not endorsed by the WHO. That's a small feature. We are not very keen on it. Can you read it?
Post-exposure prophylaxis and pre-exposure prophylaxis regimen require a series of vaccine injections according to the manufacturer's recommended schedules. Most vaccine manufacturers currently recommend for pre-exposure prophylaxis a one-site IM 3-dose regimen and PEP a one-site IM 5-dose regimen on day 0, 3, 7, 14, and 28, or 4-dose Zagreb regimen, that is 2-site IM on day 0, 1-site IM on day 7 and 21. Some manufacturers additionally include for PEP the 2-site ID Thai Red Cross regimen with 4 clinic visits on day 0, 3, 7, and 28.
23 is a mistake. Anyway, see, the thing here is that what you should understand is very, very important. Whatever you are giving, read the manufacturer's recommendation. If he doesn't recommend ID, don't give ID. Because at the end of the day, legally binding is the manufacturer's pamphlet. Remember that. Okay. That I think we can skip it. Reduce 3 doses. We have already seen this. Okay. Read it. Yeah.
What is the primary mechanism of action of rabies monoclonal antibodies? A. Inhibit viral replication neurons. B. Neutralize virus by binding G proteins. C. Enhance T cell response. D. Block blood-brain barrier entry. Neutralize virus.
We have already seen this. Okay. Anti-rabies monoclonal by ectoderm of the glycoprotein. We have already seen this. Now read this.
A child received ERIG. When should the first vaccine dose be given? After 24 hours, on the same day but a different site, only after 7 days. D. Concurrently at the same site. B. On the same day but at a different site.
Yeah, but normally it is a vaccine which is given first. They are talking that you got the equine rabies immunoglobulin. Yeah, but sometimes it happens, isn't it? The wound is there. You start giving immunoglobulin immediately. And the nurse comes and says, shall I give the vaccine? Yes, you can give, but it should be given on the same day. That's the answer, okay? Same day, but different site, never in the same syringe or location, okay? Same syringe or location. And this is very important. You knew it. It's not available on the first day. RAG can be given up to day 1st, up to day 7. Last day to give is 7. If he comes on the 8th day, you cannot give the immunoglobulin. We have seen this.
Which of the following is a sign of encephalitis in early rabies? A. Priapism. B. Ascending paralysis. C. Hydrophobia. D. All of the above, sir.
Priapism also.
Priapism.
Rose, what do you say? Early rabies, agitation, priapism, insomnia, hydrophobia, and depression. We read it last time. See, I want you to remember one thing, that paralytic rabies or ascending paralysis is one of the features of rabies. Okay. Now remember, whenever a child with ascending paralysis, how many of you have given a cup of water and asked her to drink it? It's very important. You made straight away diagnose as Guillain-Barré. But remember that it can be the feature of rabies also. And here, as I told you, even photophobia are given here. Priapism is given here. And insomnia, nightmare, and depression. Therefore, it can present in a very vague manner. So please remember, there may be no history of dog bite, or the child may not have told home. always give a cup of water to every encephalitis child and make sure he drinks it. Okay.
What is the fatality rate of clinical rabies? 100%, sir.
Yeah, it's one of the disease 100%. Very critical.
Which of the following is not a reason for underreporting of PEP failure? A, misdiagnosis as encephalitis. B, lack of confirmatory testing. C, all PEP failures are reported. D, or attribution to other causes.
Yeah.
Not a reason.
Which is the answer? Underreporting, you may diagnose as encephalitis, you may do LP, you may do what you call the MRI and diagnose it as something else. These are all underreporting. Lack of confirmatory testing. There's no it's a clinical diagnosis. You may attribute it to other cases. Okay. Therefore, what's the most important? All PEP failure are reported. The moment you give immunization, you are given this one, the patient dies, is going to be a huge issue wherever you are. You understand? Okay. All right. Now remember one thing, PEP failure, when you go from this, among many things which you carry home, is well documented. In patients who have bites on the head and neck region, it is well diagnosed, well documented that even if you give PEP on right timing, it can still create problem. There is publications which I have not quoted in this because it came to me only yesterday. Underreport anyway, PEP failure can occur, all right.
What is the role of tetanus prophylaxis in animal bites? A, not required. B, should be given if not immunized. C, contraindicated with rabies vaccine. D, only for dog bites. B, should be given if not immunized.
Yeah, even if it is immunized, it should be given. Okay. I don't know how they quoted my name in it. Okay, right. The last question.
Which of the following is true about bat rabies in India? It is not a concern.
I think this is a repetition of the question anyway. Okay, give the answer.
Not a concern, sir.
Yeah, it's not a concern, but they have given the answer. C, we discussed this. Probably not a correct answer because not a concern is the right. Here they are given underdiagnosed and genetically diverse. That's in Western countries, okay? In India, it is given that rabies, we discussed this in separate, okay? Therefore, question number 40, we can remove actually, okay? But I think we have come to the end of it. I ran through it. I might here, what you call, give an abridged version of this. I'm stopping the recording.